I am going to speak to the counter arguments about why we wouldn't want to do neoadjuvant chemotherapy prior to radical cystectomy. As you see here, I am a medical oncologist, so of course this is not my natural position on the topic. And you'll see over the next couple of days that David has set me up for 3 debates where I'm actually taking the counter position to what you might expect. But that's okay, right? I mean, regardless of what conclusion I might reach at the end, the fact of the matter is, as we always say to our trainees, right, we have to be fully versed in all of the, considerations pro and con, and the fact of the matter is that there are always exceptions to the rule, right, when we're seeing patients in clinic, and understanding these arguments helps us with that. So I'm going to walk through this, we start with the fact that the NCCN is pretty clear, right? The NCCN says that neoadjuvant chemotherapy followed by radical cystectomy is a Category 1 recommendation based on high-level data supporting its use. They go on to say that neoadjuvant chemotherapy increased median survival, as we saw in the last presentation, with no apparent increase in treatment-related morbidity or mortality. And that adjuvant chemotherapy, which might be considered an alternative, is considered a Category 2A recommendation because of what we saw in the previous presentation with a lack of data. So where's the debate, right? Case closed, that's the guideline. Except, right, so in the same guidelines we talk about patients with hearing loss or neuropathy, poor performance status, or renal insufficiency may not be eligible for cisplatin-based therapy. Right? So cisplatin is a toxic drug. We certainly know that some patients simply won't tolerate it. And that if cisplatin-based therapy cannot be given, neoadjuvant therapy is not recommended. And that's because the alternatives to cisplatin, such as carboplatin, are clearly inferior and not proven by clinical trials. And modifications to cisplatin that reduce the dose then also reduce efficacy. So really, the guideline is you have to be able to give the cis if you want to do this at all. And then, of course, there's the real world, right? So, we can't get away from this. This is where we actually live, quite apart from the world of clinical trials. So we had this data from Hannah and colleagues a few years ago, where they looked at patients in the SEER database from 2004, NCDB database, excuse me, from 2004 to 2012. And they looked specifically at patients who underwent cystectomy, queried whether or not they received chemotherapy, and looked then at the outcome, seeing how this compares to the published data from clinical trials. So they started with the 14,000 odd patients who had a radical cystectomy, eliminated just over 1,000 who had 1,300 who had a Charleston comorbidity index of greater than 0, eliminated some others who had radiation therapy or missing chemotherapy data. You end up with roughly 8,700 patients, and of those, about 1,600 received radical cystectomy and neoadjuvant chemotherapy. Now, when we look at the real-world data, no surprise, real-world populations are always different than clinical trial populations, right? Clinical trials have restricted criteria. They tend to select for patients that are more fit, typically younger than what's seen in the real world, and indeed, that's what we see here as well. So in the NCDB database, most patients who have radical cystectomy are slightly older at 68 as opposed to 63, on SWOG 8710. For some reason, the male versus female proportion wasn't quite the same. About 10% fewer or more males, I should say, on the SWOG study, 10% fewer in the NCDB database. But we get down a little further here and you start seeing the fact that we are selecting for fitter, somewhat lower disease burden patients. And the numbers that really stand out here, right, is you see, compared to SWOG had a higher proportion of younger patients under the age of 65, also then had a much lower proportion of the patients with T3, T4 disease who were over the age of 65, right? So the most difficult patients with the highest disease burden, the most comorbidities were underrepresented on SWOG compared to national numbers. And you see it here further in specifically those patients who underwent neoadjuvant chemotherapy. So again, there's always the question with every clinical trial of what is the true applicability of this data to my patients. And then you look over here and you see that in the NCDB database, the T3, T4 percentage is closer to 78%, and SWOG, it was only 61%, right? So not a small difference. But here's, the money shot. Ultimately, what kind of results do you get in the real world? And this is a very marked difference that has to give us just a little bit of pause, right, when we think about what we're doing in our clinics. And that is, whereas on SWOG 8710, the pathologic T0 at the time of cystectomy was 38%. In the NCDB database, it was only 8%. Now, retrospective databases always come with many limitations, right? And I think we all understand that. But one of the major ones with the NCDB database is that the details of chemotherapy are not recorded. We don't know what regimen was received, how many cycles, whether it was just, started then stopped, whether it was ever completed. Regardless, when we look at the survival data in Hannah's analysis, we see that the survival benefit of radical cystectomy with neoadjuvant chemotherapy in the blue line, in fact, is quite slight. But again, taking into account the limitations of such databases and the biases inherent in real-world data, we usually say that we have to assess survival in such databases from the time of the same event, so that is radical cystectomy. And when that's done here in panel C, what we see is that the survival really ends up being not much different. Most of the survival difference is captured during the time on chemotherapy. Oh, it looks like I replicated these slides. Sorry about that. So again, overall survival, all patients, weighted adjusting for patient variables, and then looking at overall survival specifically from the time of surgery. And then taking it a bit further, this is old data from Cantor back in 2011, but nevertheless, when we look at real-world patients and their renal function, in a cystectomy population, the median perioperative creatinine was 1.05, but ultimately about a third to 40% of patients were ineligible for cisplatin based on GFR and creatinine. So really very restrictive, right, once we start talking about cisplatin eligibility. We know that cystectomy, that is, doesn't affect eligibility for adjuvant therapy, so certainly, or in terms of renal function, so certainly that would then be a consideration. And then in patients under the age of 65, creatinine actually often improved, right, usually because you're relieving obstruction, about 14% in the postoperative population. So with that, the question certainly comes up, why not adjuvant chemo, right? At least then you have your pathologic staging, and you truly are selecting for just the worst actors. So the why not? Part of the problem is that no randomized clinical trials have been completed in this space because of difficulty with accrual. Now this largely comes down to the fact that postoperatively, as everyone knows, it's quite a recovery from a cystectomy, and so it's very difficult to convince patients to consider chemotherapy, at least on a randomized basis, right? Patients at that point have made up their mind about what they are not willing to accept and aren't going to be randomized. But nevertheless, postoperative staging would improve patient selection, right? As everyone knows, over 40% of patients might be upstaged, a small percentage can be downstaged, and of course, operative staging correlates very clearly with overall survival much better than clinical staging does. And then, of course, toxicity, right? So what happens then, apart from the perioperative morbidity, because beyond just asking, does this prevent us from getting to surgery, but what other toxicity does the patient suffer when going through chemotherapy? And we see here, certainly there's going to be some renal dysfunction. Myelosuppression absolutely is expected. And this was not a small consideration as we went through this period of COVID and deciding, do we want to place patients on chemotherapy and at greater risk? Certainly in the first wave of COVID, when we didn't know how severe this might be, I think this was a major consideration, perhaps maybe less so now that the perception of risk is much less and our management so much better. But regardless, as the medical oncologist, I always have to speak to my patients about the toxicities of the therapy we're proposing. So in summary, neoadjuvant chemotherapy is associated with improved overall survival in clinical trials, but real-world data certainly differs. Real-world patients are older, they have more comorbidities, and the fact of the matter is cisplatin-based chemotherapy is highly toxic. adjuvant chemotherapy allows for improved patient selection based upon pathologic staging. And that's it, with 1 second to spare.